Very important innovation. I'm not going to talk about that. So initially I thought that maybe when I have to say 5 innovations, maybe I should talk about patient population, new valves, new accesses for closure devices, new CMS guidelines, new AUC guidelines. And I thought that it would be all extremely boring if I talked about all of these things because those are things that are not really innovation. They are processes that are happening over time. So what I thought is that what I am doing differently in last 1 year compared to the year before that and in my TAVR practice, and that I would consider as an innovation that at least people can take home and say that maybe this is something worth considering. So this is how I structured my top 5 things. So they may not sound very novel, but there are some learning points for each of them. So first thing I put number 5, going backwards, to say that we like to do a high pressure valve-in-valve expansion, because now valve-in-valve is a very acceptable option for all patients. I would say that even for patients who are good surgical candidates, you could consider a valve-in-valve. And Dr. Turju, Michael Mack, and a lot of people here contributed to this paper to say that if you look at the TVT registry, it is very clear that even if you match native valve TAVR to valve-in-valve TAVR is extremely safe compared to native valve TAVR. And native valve TAVR, as you know, is extremely safe. So if you combine these two, it makes sense that valve-in-valve TAVR. So what about the small valves? And I just want to show you a case and then just describe. So this is an important slide that we make for all our patients for TAVR. So whenever we have a patient, this is our pre-cath or pre-TAVR workup, that the fellows make a slide where there is a clinical history, labs, imaging, cath, access, and then we say what are the procedural issues. Because all of these patients look very same, they're very old, very frail, a lot of comorbidities, and they run into each other. So unless we have a very clear slide, and this is projected in our cath lab in one of the monitors. So this is part of our slide. So this is a patient who has, they claim has a 23 mosaic valve. And if you look up the valve-in-valve app, it will say that you can put either a 23 self-expanding valve or they even say that you can put a smaller balloon expandable valve. Here we decided to put a 23 S3 valve inside of the mosaic valve, and as you can see that there is a waist. And if you measure the hemodynamics, as you can see on the right side, hemodynamics doesn't look too bad. But this is not good, because if you see that the aortic pressure is very different from the LV pressure, and if you are going to measure the instantaneous gradient, it's going to be high. So this is not an adequate result. So that's the first step to know. And doing an echo is not enough. Doing an invasive hemodynamics takes 2 more minutes to check the pressure is worthwhile. So what is the option? So the option is to put a high pressure balloon. So if you see here, so if you we put a 22 millimeter true balloon and expand it to 18 atmospheres. And if you expand it to it, there is some data to say that the valve in vitro, if you overexpand it, it tears. But this is not overexpanding. This is a 23 valve and we're putting 22 balloon. And if you see at the end of this, so these are the 2 pictures, still frames, before and after, and you can see that the valve expands very visibly and fairly large. And if you measure the gradient below, you see that the upslope of the aortic valve is parallel to the LV pressure. So there is no instantaneous gradient, not just peak-to-peak gradient, but there is no instantaneous gradient. And how do we do that? So this is a simple thing to keep in mind, that if you use a indeflator, put the indeflator on the closed end and keep the pressure up. So you don't have to take time. So I usually put the indeflator to 12 to 14. We published it in CCI, so this video is there. But the idea is that the stopcock is closed, you inflate the indeflator, keep the indeflator at high pressure. So when you are inflating the balloon with the big syringe, and if you flip, you already have 6 or 8 or 10 pressure inside, you can go to 18. Otherwise, if you try to turn it, it will take forever. Patient may have a seizure. So this is okay. You know, I tell our anesthesiologists that seizure is part of TAVR. So if sometimes they seize a little bit, they will come back. The internal pacemaker for rapid pacing. Very simple concept that, we have a pacemaker in the patient. Why do we put a temporary wire? You just use the internal pacemaker. Not enough data to say that this is safe, reproducible. So we looked at all our different kinds of pacemaker. We again put it as a publication, so hopefully it will be published soon. But the idea is that in whatever number of patients we looked at, we were completely safe to use the internal pacemaker. So we no longer put a temporary wire in the patients who have internal pacemaker. Sentinel device. Sentinel device now, as you know, is now bought by Boston Scientific. And as some of you know, that there are two filters, one in the innominate, one in the carotid. And on the right-hand screen, this is a live fluoro to say that how long it takes while I'm talking. So there are two. This goes through a 6 French radial catheter, and it goes from the radial artery. Here, this is the innominate filter that we are deploying. And then you slowly pull back this. I use Whisper wire. Some people use the BHW wire. I think Whisper is better because it's softer, so it lets it turn better. So now you just pull back this distal part, this little piece, back into the aorta. And now we are pulling back the distal piece. And just flex it. It looks towards the carotid. It will look towards the carotid. You can flex it a little bit more. There is a dial there. And then you just advance the small wire, in this case the Whisper wire, which is inside of it, right there. So the Whisper wire goes into the carotid artery. You have to manipulate it a little bit to align it to the carotid artery. Gently, there is no rush. And once you put the wire in the carotid artery, you can advance as the wire is now in the carotid artery. Maybe you cannot see in the back. You pull back the device and slowly advance the distal filter. You will see the distal filter coming out in a second. And that is the end of the procedure. So this takes literally that much time, which is less than a minute to put it. Maybe you can say 3-4 minutes in the trial, but it doesn't take 4 minutes. And the data, the reason why it got approved by the FDA was we presented it very candidly that we had the primary endpoint not right because we say lesion volume, and lesion volume patients don't care about lesion volume, they care about stroke. And the strokes were much reduced, 63% in this particular slide at 72 hours. So there is a clinical benefit, and now a lot of retrospective data showing, and in our case, we did 265. I wrote a letter to Medicare to say that we should have reimbursement because all these 265 patients that we used last year, we didn't have a single stroke. Same groin access. So I stopped doing 2 groins. There is no need to put a 2 groin access, crossover, and all this. It's too much. So just go in 1 groin, inject the dye, just stick below. I don't even inject dye or anything. Just stick few centimeters below, maybe in the common SFA or profunda, doesn't matter, or SF, wherever, because you're going to hold pressure. And at the end of the procedure, you just remove the big sheath and you check from the below sheath if the groin is good or not. If it's not good, put a 5, 6, 7 millimeter balloon, dilate it. So you can just put it from the sheath, balloon dilated. So there's no need for crossover wire. There's no need for, and 1 groin. So next day morning, you just check 1 groin. You don't have to check 2 groins. And patient feel good because they didn't have both groins instrumented. So this is our standard now. So here you can see 2 groins. And I use 1 Perclose, no 2 Percloses, just 1 Perclose. At the end of the Perclose, if it bleeds, no big deal, I put an angiosil. So this is another very important advance that 2 Percloses sometimes pinches the artery. So if you just put 1 Perclose and if it bleeds, put angiosil on the top so it doesn't bleed. So it is 2-way closure, 1 stitch and 1 collagen. And here you can see that, because you have a wire there, you can just put an angiosil. The hole is never bigger than 8. If it is bigger than 8, if you think it's a lot of bleeding, then of course you use your judgment how you deal with it. Sometimes you can put more than 1 angiosil. And the last one, I say, I didn't put it there, but it should be the accurate placement of the aortic valve. What is an accurate placement? So most people put the valve in an LAO projection. I'm talking about the balloon expandable valve. So most of the people put it and they use a pigtail catheter. So first thing we did is that don't use pigtail catheter, we use a straight flush catheter, straight. So you put it straight into the bottom of the non-coronary cusp. So now the catheter is in the bottom of the non-coronary cusp, and you are now checking the RAO caudal view. As you know that the aortic plane can be checked in RAO to LAO, whatever view. Why RAO view? So here you can see we are deploying the valve exactly at the native annulus. So the last link of the valve is at the last link. And how can you accomplish that? How can you accomplish that is very simple. Is that if you look at you align like how you align a Medtronic valve with the rings, you can align the S3 valve so that you are squared. When you are squared, you see the link. You see the bottom link. You see that white line of the stent. So you can see this white line to say that this is the link. If you line up the link, this is how much it foreshortens. So it's just lucky that it foreshortens exactly the size of the link. So if you are going to not underinflate it, it will foreshorten exactly the size of the link. So you can just take the link, place it there, and inflate. So very, very simple. Why it is so important is, of course, that there is a conduction system, and you want to seal the interleaflet area. You don't really need to seal the mitral valve. So if you have a cuff there, it is not as good, because what are you going to seal there? So it is better to seal where you have the intercommissures. And that is what I show in there, that where the seal is and when our valve is, that it will seal properly. If you look at the LAO view, because we have a biplane lab, so same patient, you have an LAO view, you will see that you will feel uncomfortable, that this is the valve that is almost outside, that, you know, the valve is, it looks like it is outside. And if you look at the RAO view, you will see that the non-choroid cusp is a little bit lower. All the surgeons will tell you that non-choroid cusp is a little deeper than the right and the left. And so that's why to see the non-choroid cusp is the most important part of the catheter. And here, if you look at the post-implant depth, see in the LAO view, you feel uncomfortable, that this is all awfully high. It is not. And if you look at the CAT scan of the patient, if you bring the patient back to the CAT scan, and you will see on the upper corner right there that the valve is just below the right choroid cusp, right at the non-choroid cusp. So it always sits like that too. So that's why I think that putting a valve in an RAO projection is a helpful technique to be very, very precise. And so, for example, last year we did 500. We did not have a single embolization or anything like that. And our pacemaker rate is less than 5% with the S3 valve. So, and we had 4 patients with AR, and which was graded as 2+. This is the patient that I just showed you. This is the echocardiogram, and there is no aortic regurgitation. Finally, the top secret, I said, is that the procedural log. So we don't publish this anywhere because we don't want less reimbursement. We start at 8:47, finish at 9:15. We put Sentinel device, this thing, that thing, close the groin. So 26 minutes, and we are not rushing. So this is a simple procedure. This is not a difficult procedure, and very reproducible. Planning is everything. So people ask me, say that, show us a difficult case. There's no difficult case, because if you had a difficult case, you plan differently so that it doesn't become difficult. So that is the beauty of TAVR. Thank you.